Uh, Thank you. And I'd like to thank the Movement Disorders Foundation of Arizona and Dr. Jerry Evidente for inviting me to give this talk today. So, gastrointestinal issues are common in Parkinson's disease, and Parkinson's itself is, it's prevalent. Approximately 6 million people that we know of in the world have Parkinson's, and more than a million in the US itself. And a lot of the focus ends up being on motor symptoms of Parkinson's because that's what's obvious to everyone. So we see the tremor, we see the stiffness, the slowness, the balance problems. What goes sort of less noticed, but sometimes even more problematic, are the non motor symptoms. And some of the non motor symptoms can be some depression, some memory problems, sleep problems, sometimes hallucinations. But what oftentimes is a very early and continues to be a very problematic symptom is the GI symptoms. And some of the GI, one of the top ones probably is constipation. Constipation can be something that can be common and problematic in Parkinson's disease. And there is this whole hypothesis and emerging concept about the gut brain connection. And basically, what happens is that because constipation is such an early sign or symptom in Parkinson's, that people started probing more into, well, is could that be a portal of entry perhaps that could be leading to Parkinson's? And what people have found, as I'll show in my subsequent slides, is that it's possible that Parkinson's is actually starting somewhere in the gut and then spreading up to the brain. So, you might be familiar, you've probably heard about these abnormal uh, collections of protein that are associated with Parkinson's, and they're called Lewy bodies. And the Lewy bodies are basically, found in Parkinson's, and they consist of alpha-synuclein. Now, they actually have done biopsies in various body parts or on autopsy studies, and they found that there's a high frequency of these Lewy bodies in the jaw, in the esophagus area, or the food pipe. And there's also these Lewy bodies are present in the stomach and the gut, all the way from the small intestine to the large intestine to the rectum. And the locations that are closer to the brain seem to have a higher frequency of these Lewy bodies. And so there's this famous pathologist, Brock. He has this hypothesis that says that the Parkinson's pathology actually starts in the gut and spread backwards to the brain via the 10th nerve, which is a vagus nerve, which supplies the whole GI system. And so it's possible that this abnormal protein, which is alpha synuclein, which makes up the Lewy bodies, is maybe spreading up from the gut into the brain. Now, this abnormal alpha synuclein can sometimes be observed in the gut as early as 20 years before the time of diagnosis. And there are two kinds: there's the sympathetic and the parasympathetic. So in this system, the parasympathetic neurons are involved. And it's possible that as this happens, the gut slows down, and that may be contributing to some of these symptoms of maybe swallowing problems or constipation. And as this alpha synuclein spreads from the gut up the 10th nerve and into the brain, it could be contributing to loss of dopamine. And this alpha synuclein or the Lewy bodies are eventually what we find in the brain that cause Parkinson's. Now, here, if you see my cursor, you'll see the brain and then the spinal cord. And there's this 10th nerve that supplies the entire gut. So when they do biopsies, right, they can find in the gut, if you go in, there's evidence of inflammation and Lewy body formation in the lining of the gut. Now, Parkinson's interferes with the GI system, and you'll see on the left side, the normal, we have the the stomach and the gut, and this is the 10th nerve that's ascending into the brainstem. Now, in Parkinson's, now the gut itself, all of us in our gut, we have, bacteria. And the bacteria are very vital in digestion of food and keeping the gut moving. In Parkinson's, because there can be this ascent of via the vagus nerve of these Lewy bodies, it can cause GI disturbance, which causes decrease in the motility of the GI system. It can cause constipation. It can also cause pain because when someone's constipated and is straining, it can lead to pain. And then surrounding constipation, there can be a lot of depression and anxiety and behavioral changes. And inside the gut, there is also an upset in the typical bacteria that you see. So the bacterial composition inside the gut may change in Parkinson's. Now, one of the top things that one might see might be drooling. So sometimes there'll be a little trickle of saliva in the corner of the mouth. Sometimes people will feel that just when they wake up, they find some crusting on their chin, or they find a wet patch on their pillowcase. Oftentimes, the increased drooling will happen more at night. And then sometimes it may extend into the daytime. All of us, when we eat, we make more saliva. So if there's already a baseline increase in saliva, and then while eating, the saliva goes up. So some people will find that their mouth gets too full with saliva, and so it can be hard to sometimes chew and get the food down well. And that can lead to dysphagia. So some people can have trouble swallowing, and that may or may not be accompanied with increased salivation. Now, all of these things can form a setup for aspiration. So if there is trouble in swallowing, if there's too much saliva there, that leads to trouble in chewing and adequately swallowing. Sometimes there can be aspiration, and the aspiration can be silent, in which case one doesn't actually realize that one has aspirated. But when when one goes to the ER with a cough or a fever, they find some pneumonia there, and that's sometimes the first sign that there's actually been some aspiration. Sometimes it can be more obvious aspiration. So people are chewing and swallowing, and along with that, there could be some cough. And most of the time, the cough is more with kind of dry, crumbly food like salads or steak, etc. So a little food that's a little bit more moist generally it's easier to swallow it down. The top thing to do would be, if one is having trouble swallowing, to be evaluated by a speech therapist. The speech therapists are also swallow therapists. So they're speech and swallow therapists. And they can actually watch you eating food of different consistencies and give you tips on how to make swallowing safer. Now, if we see the GI, just the upper GI, there can be choking, there can be coughing. Sometimes it might feel like the food is stuck and one might actually have to cough it up. One could have a weak or a soft voice. When there's aspiration, it can get the food or the liquid into the lungs. There can be extra saliva, difficulty chewing, especially if one is off, right? If the Parkinson's meds aren't working that well between doses. Sometimes just the chewing can be hard. Sometimes there can be jaw tremor or tightness, which may make it hard to chew food adequately. And then when one is off, it can be sometimes hard to move the food push the food bolus from the front to the back of the throat. And then one can get a sensation that food is sticking in the throat. And why does this happen? So, they've actually done studies to see that, do people with Parkinson's make more saliva? But actually, they don't. They don't necessarily make more saliva, but what happens is that the spontaneous ability to swallow saliva is less. So people may be making the same amount of saliva, but they have less spontaneous swallowing. And as a result, the saliva builds up in the mouth. It's sort of like if you're sitting in the dental chair and your mouth is open, you're not being able to swallow. And so the saliva kind of builds up in the mouth. So that's what happens here. People have less spontaneous swallowing, so the saliva is building up. And then, because of the slowness that Parkinson's can cause in the voluntary muscles, there can be reduced ability to control the tongue as well as the upper part of the esophagus. Now, all of this can sometimes lead to poor nutrition, and so it's important to keep an eye on the weight. Now, what can one do for the extra saliva? When there is something on your mouth, in your mouth, and you're chewing it, the body activates more of the voluntary swallowing rather than just depending on the involuntary swallowing. So if one is chewing on gum or sucking on hard sugarless candy and one chews on it slowly, then the swallowing mechanism gets activated, and along with that, the saliva is likely to go down. It also helps to chew slowly and clearing the throat before taking bites, and eating with the tucked chin. That's extremely important. It's called the chin tuck approach. Now, what happens is if we eat with our chin tucked, meaning our chin closer to our chest, then a natural valve forms that makes it harder for us to aspirate. Now, oftentimes, what happens is we are distracted, or we have the television that's sort of higher up on the above the fireplace. And if one is kind of extending their head back and looking or raising their head to look at the television, if it's at a higher level, oftentimes that leads to us extending the neck. And that makes swallow less safe. So it's important to, when you are eating, to be somewhat less distracted. That's true not just for Parkinson's, but for anyone really. It's better to focus on eating, have less distractions, avoid hopefully talking while we are eating. And all of these strategies can decrease the risk of aspiration or choking for anyone. If you see a speech therapist, they work on other things such as body posture, other than the chin tuck approach, that can make swallowing safer. Now, if saliva is becoming more bothersome, the extra saliva, then there are medications that can decrease saliva production. However, one has to be cautious because some of these meds can sometimes worsen memory or maybe even cause excessive dry mouth. So, but there are some oral meds, but they have to be used with caution and only under your physician's guidance. Rarely scopolamine patch, but again can sometimes cause confusion. Atropine eye drops, rare cases where sometimes one can put that in the mouth temporarily. It gives only benefit for an hour or so, but in some situations it is appropriate to use atropine eye drops on the mouth, which will temporarily dry the mouth. Your more long-term approach uh, can be injection of botulinum toxin. Now, the two medications that are approved for this indication are Myoblock and Xeomin, and they are injected into the salivary glands. Now, the salivary glands, we have a lot of salivary glands, but the main ones are the parotid and the submandibular glands, and that shows the location. We also have a bunch of little salivary glands inside the mouth that's hard to approach with the botulinum toxin. However, if we are able to inject and approach these more superficial salivary glands with botulinum toxin injections, then it's possible to get almost up to 3 months of benefit. Now, The needle is quite small and the injections are not deep at all. They don't need too much guidance, and it can sometimes be a quick office procedure. Assuming, obviously that one hasn't had surgery in that area, etc., that's altered the anatomy. If it's just typical drooling, no previous surgical surgery on the face, then this can be done in the office and it can provide relief for up to 3 months. Now, several of you may be interested or you might have read about the role of gut bacteria in absorption of nutrients. So, when there is fermentation of non-digestible substrates like dietary fibers or on the intestinal mucus, then that can lead sometimes to growth of microbes that produce short-chain fatty acids. Now, overall, drugs are transformed to their more active metabolites. For instance, the main one in Parkinson's, which is carbidopa levodopa. Levodopa itself is not active, however, it's broken up by dopa decarboxylase into dopamine. And the gut bacteria, they can affect this metabolism of or the conversion of levodopa to dopamine. Patients with Parkinson's, when there is slowing of the gut and the food and the intestinal mucus, etc., are sitting there for longer, sometimes there is an abnormal increase in bacterial population, and that's called SIBO, or small intestinal bacterial overgrowth. Some of the symptoms can be loss of appetite, there can be some abdominal pain, there can be a sensation of bloating, sometimes diarrhea, there can be weight loss, malnutrition. Now, some of these can even are common enough symptoms, they could happen even without SIBO. But GI doctors, if one is having significant symptoms such as pain or loss of appetite, it's generally a good idea to see a GI physician because one has to check that there's nothing other than Parkinson's that could also be contributing to these symptoms. So some of the symptoms that are related to the stomach could be bloating, indigestion. There can be a sense of early satiety or early fullness. And this is due to delayed stomach emptying. So we know that the vagus nerve or the 10th nerve, it is supplying all of the gut, and that can be affected in Parkinson's. Sometimes some of the GI symptoms can be secondary to irritable bowel syndrome, which can cause abdominal pain or alteration of bowel movements. So again, if there are significant enough GI symptoms, it's good to have a GI doctor as part of your team. Nausea and vomiting, they can, a lot of the Parkinson's meds, including carbidopa levodopa or the dopamine agonists such as Mirapex or Requip or Neupro patch, all of these pro-dopaminergic drugs, they can cause nausea. And, we all do hear that, we should take carbidopa levodopa on an empty stomach to promote absorption. However, if one does have significant nausea from carbidopa levodopa, then if you do take it with food, there's a chance that you may have less nausea. So if your meds do cause nausea or vomiting, then make sure you check with your prescribing doctor. One of the major issues in Parkinson's can be some delayed gastric emptying. And levodopa itself is made of amino acid. Proteins are made of amino acids. And sometimes what happens is if you eat a food that's rich in protein, such as meat or eggs, or among the plant foods like peanuts or nuts, and they both reach your upper intestine at the same time, sometimes the body will preferentially absorb the protein in your food versus the levodopa. And due to that, you may take the levodopa, but you may not be able to absorb all of it. So it is generally a good idea to try to take the levodopa at least 30 minutes before a meal, or if you're taking it after a meal, to try to delay it by approximately 60 minutes. Now, the stomach, normally, we'll see that normally the food moves from the stomach to the beginning of the intestine, and that's normal digestion, and there's a certain rate at which it moves. In Parkinson's, because the stomach and the intestine are sort of not moving as well, the food stays in the stomach longer. And as the food is staying in the stomach longer, people sometimes will eat maybe half the meal as what they used to, and they'll feel that they are full. So, one of the treatments for delayed gastric emptying can be having small, less frequent meals. Because if we look at the previous slide, right, the stomach's not moving, so there's sort of only half the stomach available for eating food. So if one has small, less frequent meals, it may be easier to maintain weight. Exercise, because it tones up the abdominal muscles, can help with the the more toned abdominal muscles can help the intestine move, and that can promote gastric emptying as well as prevent constipation. The ones to avoid are medications such as metoclopramide, which is also called Reglan, because these medications are dopamine blockers. So if one takes medications like metoclopramide, they actually are dopamine blockers, and they are working opposite to what your carbidopa levodopa is doing. So those are meds to avoid. Those medications do help with gastric emptying in your typical patient population, but need to be avoided in patients with Parkinson's. Also, it helps to have dietary modifications such as small bites, maybe food that's chopped into smaller bits, or if it's significant, then maybe blended food. So there's less work for the gut, for the stomach to do. Now, some of the symptoms that can arise from the lower part of your gut can be due to the could be due to the slower transit time. There can be constipation. Also, when one is constipated, then sometimes the stool gets dry. And when it's dry, then one ends up straining. So that can lead to pain or abdominal cramping. And then when the stomach is emptying, when the stomach emptying is delayed and the bowel movement is slow, that can delay the onset of time it takes for the levodopa to work. So if typically levodopa takes about half an hour or so to work, if someone is having slow movement of the gut and the intestine, it can get delayed to 45 minutes or even longer. Now, if one is constipated and is straining, then there can be hemorrhoids or tears or fissures. And so with these, one has to, so it's a good idea to keep your gut going and not to get very constipated. So now some of the meds that are used for Parkinson's can also be somewhat constipating. And top of those are your anticholinergic meds such as trihexyphenidyl or Artane. That is sometimes used for tremor, but it can be constipating. For some patients, amantadine can also be somewhat constipating. So if one is constipated, it helps to have exercise again to tone up your abdominal muscles, so it can help with pushing, with moving, the stool through the intestine. Enough fluid, and that typically means at least 6 cups of water a day, and increased fiber intake. And that can be your fruits and vegetables, less processed food. So the more sort of natural fruits, vegetables you have, the more likely you're going to have enough fiber intake. So constipation and Parkinson's, Some studies have looked at whether probiotics could be helpful, and there's some early data that possibly probiotics may help with treatment of Parkinson's. Some way you can have probiotics is also yogurt. Yogurt has, good bacteria, so that could be one natural way to replace good bacteria in your stomach. Healthy eating, which all of us should be doing. This is not specifically for Parkinson's, but for everyone. But maybe even more helpful. It's good that what all of us should be doing is also what you don't have to necessarily drastically change your diet for Parkinson's, just eat a normal, healthy diet. And we know you might have heard the term Mediterranean diet, in which there is more whole grains, more healthy protein. The whole grains, a variety like whole wheat bread or whole grain pasta or brown rice. Limit refined grains like white bread or white rice. And even when you have protein, fish might be the better option, poultry, beans, nuts. It might be a good idea to limit red meat and cheese, avoid cold cuts and other processed meats. Again, the less processed the food, the more likely you're going to get more fiber out of it. Eat plenty of fruits. And they say that the more colored your fruits are, so the more colorful your plate is, the more healthy it's likely to be. And again, we are talking of unprocessed food. So we are talking of different colored fruits and vegetables. So the more veggies and the more the variety, the better. And the potatoes and French fries don't count. Use healthy oils. Some that might be healthy might be olive oil, canola oil. There can be other healthy oils too. And then use it for cooking on salad, and then limit saturated fat and try to avoid trans fat. Water, try to drink enough water. You can have tea or coffee. Try to limit the amount of sugar that one can get through these beverages. And the dairy, should be hopefully limited to 2 servings a day. However, some people may need 4 servings a day for the calcium that they get through dairy. Juices, one small glass a day might be okay. I would one If one is having a lot of fruit juice, one has to be careful because it is acidic. And sometimes some people will complain of heartburn, and some of the ready made juices will have a lot of extra sugar placed in it. So just keep an eye on amount of fruit juice, and try to make the main beverage water if possible. So, dietary recommendations, what we just discussed in summary: vegetables, nuts, berries, beans, poultry, whole grains, red wine. One can have a little bit of wine, but I wouldn't go out of your way to drink more wine because it could worsen balance problems. Um, no whole nuts, popcorn, hard candy, tough meats if one is having trouble swallowing. And if one is having trouble swallowing, then again, softer food, thicker liquids, pureed food might help. Now, in Parkinson's, there can be several reasons to have weight loss because we just saw that it affects the whole of the GI system. And there is some decrease in smell. There is decrease in taste, due to which food may taste more bland and less enjoyable. There can be nausea, which can suppress appetite. There can be some dyskinesias or tremor, which can make eating hard. Swallowing can interfere with eating. Sometimes depression will lead to poor appetite. And then sometimes what happens is if people are taking levodopa several times in the day, then if they're trying to follow the rule of the 30 minutes before or the 1 hour, or eat, 30 minutes before or 1 hour after, it can be very tricky to just find enough time windows to eat. So while it's a good idea to try to follow the restriction of separate levodopa with food, one has to keep an eye, and one may need to lax up a little bit on the recommendations if one is taking levodopa with a lot of frequency, because you do want to be able to maintain weight. So sometimes people, before they are diagnosed, they'll have lost weight, but then generally when levodopa therapy is optimized, they tend to their weight tends to stabilize. Parkinson's itself shouldn't cause long-term weight loss, so if that happens, it's a good idea to look for other causes. Sometimes if one is very dyskinetic, like moving a lot, that's like working out, and that can burn off a lot of calories, and sometimes that'll cause weight loss. Sometimes deep brain stimulation surgery will cause weight gain. And sometimes people will notice, like easily right after DBS, almost a 10-pound weight gain. But oftentimes, patients with DBS have actually lost weight before due to dyskinesias. So a 10-pound weight gain sometimes is not much of a problem, but it's good to be aware of that possible side effect. Sometimes dopamine agonists will sometimes cause binge eating. If that happens, let your doctor know. And then sometimes some of the medications that are used, the antidepressants or the medications for hallucinations, can, as a side effect, have weight gain. Um, so we just went over this. We don't exactly know the mechanism, but when one puts electrodes inside the brain for DBS, it can help a lot with the disabling tremor. It can help with the wearing off. It can help with dyskinesias. And maybe one of the reasons why there's weight gain, maybe because there's less dyskinesias, but there may be other mechanisms that we are not aware of. The reduced sense of smell, it's actually a very common symptom with Parkinson's. It can happen very early on, and that's where they think might be another place where Parkinson's starts. So there's thinking that maybe it starts in the olfactory bulb that's above the nose, those little nerve fibers, and it may be extending from there into the brain. So, smell loss, very, very common in Parkinson's. It's good to be aware of it, and then maybe adjust your cooking or your eating accordingly. Because if food doesn't smell as good, then it does not taste as appetizing. So, it may be needed to make your food a little zestier, by adding more seasoning, so that it stimulates the taste buds more to compensate for the lack of sense of smell. Reduced, there can be some reduced taste, and so the combination of reduced taste and smell can make food less appetizing. Now, how do we just discussed that, there's so many ways in which we can have less, you know, less appetite or taste. So there can be, we can use inhaled levodopa, or it's called Imbresia, so that you can bypass levodopa and inhale it rather than, so some people can take baseline oral levodopa, but then if they are having off symptoms, and sometimes when one's off, the stomach also sort of goes off. So taking more oral levodopa may not be helpful. But if one can inhale the levodopa through an inhaler, sometimes it can bypass the stomach and get absorbed through the lungs. And so inhaled levodopa or Imbresia is one of the available ways to bypass the stomach when one is off. There can be transdermal delivery of drugs too. So there's the apomorphine pump or the apomorphine infusion pen. There's also, the Nupro patch. So these medications can bypass the stomach, and so if one is off, it's somewhat less dependent on your oral absorption. Now, none of these are typically a replacement for levodopa, but it may be an adjunct to levodopa. There's also sublingual apomorphine. So it's a little strip, sort of looks like a Listerine breath strip, and you put it under the tongue, and it gets absorbed very quickly, and it can turn one from an off to an on in about 20 to 30 minutes. And this product is called Kinmobi. One can use it when one is off, put it under the tongue, it gets absorbed quickly into the bloodstream and can turn one on. Again, it's an adjunct to oral levodopa. Injected delivery, we talked about apomorphine injections, and there are other meds in development too. So, how about, so there are also mechanisms, we are trying to do research to improve our understanding of Parkinson's disease. And there are markers that we can find for Parkinson's that exist in the saliva or in the stool samples. So those are research opportunities you may find where you could possibly sample and see if one has the biomarkers for Parkinson's in the stool and saliva. And hopefully one day these will become more mainstream, where we can use them as biomarkers to either track how Parkinson's is doing or, for initial diagnosis of Parkinson's. But currently, the research trials are on to try to develop these as mainstream tests. So with that, I'll finish up my presentation, and thank you very much for giving me this opportunity to present.